is Ellis, and I'm going to be discussing vasopressors and your inotropic agents. The objective of this video is to help you clinically understand the physiology of your vasopressors and how they act on the system to better help you make a clinical decision of what drug and what vasopressor to use. A little bit of background: your vasopressors are a class of drugs that elevate your mean arterial pressure, and that's that pressure that's going to have enough pressure to perfuse your body in times of need. Your inotropes, they increase your cardiac contractility, and many drugs of the vasopressors have a inotropic effect and a conotropic effect, meaning that they're going to increase your heart rate and increase your contractility, or one or the other. And we like to keep a main goal and for a therapeutic range of keeping our mean arterial pressure above 60, and that is a good measurability to make sure that we are able to perfuse our body adequately and perfuse our brain. Vasopressors are such as norepinephrine, which is ephedrine, epinephrine, dopamine, and dobutamine. We have the receptors physiology, and the main categories of the adrenergic receptors is relative to your vasopressor's activity. This is very important to understand which drugs act where and what the receptor is acting on. Is it an alpha-1 adrenergic receptor, a beta-1, or a beta-2, or dopamine? This is a diagram that helps you understand. During such situations such as septic shock, often pressure builds and then causes vasodilation in areas. And I have drawn this diagram to show you the different effects. We have the heart, the brain, the liver, and the kidneys. Often dilation occurs here, and we want to counteract that so we don't have hypotension and hypovolemia. And we want to make sure we keep an even distribution of blood to all organs. We do not want more blood going to the brain, or more blood going to the liver, or more blood going to the heart. So we have alpha-1 adrenergic receptors, and they act on constriction. Then we have beta-2, which act as relaxation, and then we have beta-1, which will increase heart rate, which is your inotropic effect. So we have your alpha-1 adrenergic receptors that we just talked about before, and we have your vascular wall causing vasoconstriction, which we just talked about here before, how it's going to vasoconstrict on the vascular wall. And you're wondering, how is it going to vasoconstrict and vasodilate? Well, we come down here and we see that the beta-2s act on the blood vessel, vasodilating. So this is how you can understand that we have vasoconstriction on the vessel wall and vasodilation. Vasoconstriction on the vascular wall and vasodilation on the blood vessels. We have your beta-1, which is going to increase your inotropic, which we talked about before, which that's going to increase that contraction, and also increasing your conotropic effect, which is going to increase your heart rate. This is important to remember because these drugs, you're going to have to watch and monitor your heart rate. So we know that beta-1s are going to increase that heart rate. Then we have the dopamine, which is going to be a vasodilator. Here we have the different drugs for vasopressors, and we have vasopressin, and you can see the dose. And vasopressin is pure vasoconstriction, acting on your ADH. And then we have neo, and it's mics per minute, and its main job is going to be your alpha-1, and we remember that alpha-1 is going to be vasoconstriction. We also have your neo again, and neo is going to have a little vasoconstriction, a little increasing your heart rate with your inotropic effect and your vasodilation. So Levophed is a very good judge of choice because we see that it has a little bit of everything here. Dopamine is also something that will help treat your hypotension, and it has a little bit less vasoconstriction, a little bit more increase in that contractility, and still affected that heart rate. In practice, I always am aware that dopamine increases the heart rate more so than your Levophed. So if you're septic and already tachycardic, we choose more to go toward the Levophed. But again, this is enhancing your sympathetic nervous response and shoving all of that blood to your major organs. So we have to be mindful to check for other system organ failure. Here again, we have the adrenergic effects and the beta adrenergic effects. And again, it's described in this line. The clinical indications, we have septic shock, and that can be treated by Levophed and Neo. Heart failure, dopamine and dobutamine. And then, because we have those for your vasodilation, cardiogenic shock, we have Levophed and dobutamine. And anaphylactic shock, we have epinephrine. And neurogenic shock, we have Neo. I remember that by N, and N is neuro and Neo. And then we have Neo for hypotension and also adrenaline. Here on the pharmacokinetics and pharmacotherapeutics, we have absorption, distribution, and these are all very common because these vasopressors are often in critical drips and they have a very short half-life. So we're looking at an onset of 5 minutes, a duration of an average of 10 minutes, and a very short half-life because when you turn the pump off, the medication's usually, usually not lasting too long. Elimination in 2 minutes, and it's excreted in the urine. Monitoring, we're going to monitor for hypoperfusion. We're going to monitor, and that will be to your distal organs, such as your kidneys. So we're going to look at urine output, and we're going to look at liver enzymes while we're on Levophed for a long time. Dysrhythmias, because we know we have that inotropic effect, and we're going to be in that conotropic effect, and we're going to be increasing that heart rate. Your myocardial ischemia and local effects, we'll look for decreased pulses in your lower extremities and signs of hypoperfusion, which will be dusky skin, tones, muffled pulses, and of course your hyperglycemia. Patient education, you're going to talk to them about the condition and the medication side effects and the route. These are going to be critical medications, often going in a central line. Lifestyle management, we need to make sure what drugs they're on. Often these vasopressors are contraindicated with such drugs like MOA inhibitors and TCAs, and also contraindicated in pregnancy. Again, this is more information on your drug classes for better understanding. Just understanding the appropriate clinical application is important here. And I have references to list, and this is a wonderful drug, and thank you for your time.